Dear colleagues, welcome to Module 2 of our webinar series brought to you by LUTS in conjunction with the EAU and the EU guidelines. This webinar tonight is on outstanding challenges in medical treatment of male lower urinary tract symptoms and benign prostatic enlargement. My name is Christian Gratzke. I am a urologist from Freiburg. I will be moderating this webinar, and I'm very pleased to present to you two excellent speakers who will present cases of monotherapy for LUTS and combination therapy. This is meant to be as a preparation for our live webinar taking place at March 23rd at 6:30 p.m. Central European Time. So let's start with the first talk brought to you by Dr. Tarkan from Istanbul, an expert in monotreatment for male LUTS. Please, Dr. Tarkan, the stage is all yours.
Thank you very much, Christine. It's really a great pleasure for me here with you in this webinar and with my friend Jean-Nicolas. I would like to thank, first of all, the European section of Female and Functional Urology, the European Guideline Committee, and the European School of Urology for this very kind invitation. So, as you said, my task in this webinar will be to discuss the monotherapy in the treatment of male LUTS that is associated with benign prostatic enlargement. This is my disclosure slide. So, the EAU guideline gives us the choices for monotherapy as follows. Our options are alpha-1 blockers, 5-alpha reductase inhibitors, muscarinic receptor antagonists, the PDE5 inhibitors, beta-3 agonists, and phytotherapy. As we can easily see, all these options have very different pharmacological actions and pharmacological properties compared to each other. So it's a quite challenging issue, actually, to find the best treatment modality for each patient. Because here we don't have any index patient. We are dealing with a pathology that has multifactorial etiology. And also, if we just urodynamically evaluate these patients, we will face three different urodynamic diagnoses. These are benign prostatic obstruction, detusor underactivity, and detusor overactivity. And unfortunately, in the most of the cases, we are treating our patients without knowing these urodynamic background. So therefore, actually, there is no single correct or the best recipe that will work best for each patient. So our job is just making a clinical tailoring and find out the best treatment option for each patient. And before, of course, continuing with the medical treatment, I would like to emphasize the importance of watchful waiting and behavioral and dietary modifications, because also the EAU guideline clearly emphasizes that we should offer to our patients who have mild and moderate symptoms and who are minimally bothered the watchful waiting option. And also, some of our patients will benefit from behavioral and dietary modifications, and we should not miss that opportunity. So I would like to share with you this case of a 60-year-old gentleman with benign prostatic enlargement and lower urinary tract symptoms. This is a case that we very commonly see in our daily practice. His IPSS is 19, and he has mostly emptying symptoms. His quality of life is 4 out of 6, which means he is unhappy most of the time because of his symptoms. He has a normal active sexual life. He has only abdominal ultrasound, a prostatic enlargement of 50 milliliters. He doesn't have a median lobe. His PSA is 1.5. And you see the average uroflowmetric result. We usually do at least 2 uroflowmetric studies on each patient. So his Qmax is 11, average flow rate is 6, and voided volume is 350 milliliters with a residual urine of 55. And you see the uroflowmetric curve on the slide. So my question, what would be your best choice to offer to this treatment-naive patient after conservative measures have failed? Would you like to insist? Would you like to offer alpha blockers to this patient? or maybe 5-alpha reductase inhibitors? Or would you like to discuss with the patient the option of surgical management? Or do you have any other suggestions like other medical treatment option, or just starting with combination therapy from the beginning?
Tufan, this is a great case. Thank you very much. Can I just ask you one very simple question for our audience? When do you consider a prostate large?
Yeah, the normal prostate volume that is between 18 to 20 milliliters that we see in young men is usually our indicator for that. But this is a very good question, as you said. If you look to the literature, usually 25 or 30 milliliters of prostate sizes are chosen as the start of the enlargement.
Jean-Nicolas, can I direct that question maybe to you? Can you give us your estimation of what you would do with this patient, 60-year-old healthy man, treatment naive?
Yeah, I think this case, as Dr. Tarkan said, is very common. This is probably the most frequent case we have, and among these options, I would say if conservative measures have failed, if the patients come to you, maybe he's looking for something to make his life better. So that's why I wouldn't go for watchful waiting here, because if the patient is here, he needs something more. And if the conservative measures have failed, I wouldn't choose watchful waiting. Alpha blockers is the other option. It's considered as, you know, one of the most common choice recommended by the guidelines. So this is an option we could consider for sure. And the patient is showing maybe voiding symptoms. So that's probably a good choice. 5-alpha reductase inhibitors, it can be also discussed, probably as an alternative to alpha blockers. It is good to notify, in line with the question you asked before, that here we have a really too big prostate. We have here a prostate of more than 40 milliliters, who is something I would say necessary to discuss the 5-alpha reductase inhibitors. Probably the case is too early for a surgical management because the risk-benefit balance in that case, without having tried medications, is something too early. And I'm very glad to Dr. Tarkan to have positioned in other, because I think the phytotherapy can be proposed to that guy. It depends on the situation of your clinical health system, on the reimbursement, of the access to this kind of drugs. But for sure, if you don't want any secondary adverse events, this could be something discussed, and sometimes patients themselves are asking for that.
So basically, if I may summarize, your primary endpoint here will be to increase the quality of life of this patient, right?
Yeah, definitely.
All right. Dr. Tarkan, please continue and enlighten us what you would have done with this patient.
Thank you very much. So actually, I have asked this question in many other meetings, and the most common answer that I received was the alpha-1 blockers. Usually, all around the world, the urologist's attitude is to start the alpha blockers first in such patients, and then see what's going on, and then add maybe other medical treatment modalities if the symptomatic outcome is not satisfactory. So, so my answer to this question would be to start alpha-1 blockers with that. The phytotherapy option is also a very actually valid option, but depends on the really health system of different countries. So if I may continue with my next slide, actually, so what we know about alpha blockers as the most commonly utilized medical treatment option for male LUTS. Well, first of all, we do not precisely know the mechanism of action. There is, of course, the hypothesis that the prostate tone is reduced, and so it's affecting or decreasing the bladder outlet obstruction. But this further needs clarification because the literature lacks placebo-controlled randomized controls here. But recent data suggests that all alpha blockers actually decrease the bladder outlet obstruction index. There may be other possible mechanisms involved in the mechanism of alpha blockers, such as their effect on urinary bladder smooth muscle, or spinal cord level, or blood vessels in the pelvis and in the bladder. We know that alpha blockers do not affect the prostate size. The EAU guidelines actually finds all available alpha blockers at the same efficacy, and these are all strongly recommended. And they have also a rapid on to emphasize regarding alpha blockers, especially compared to 5-ARA inhibitors. So randomized control trials actually reveal an IPSS decrease by 30 to 40%. This is actually involving both storage and voiding lower urinary tract symptoms. And the Qmax is increased in these patients between 20 to 25%. The bladder outlet obstruction index may be here a more relevant parameter actually. And this is of course a finding of pressure flow studies. As said, unfortunately, we lack randomized controlled studies to really understand what's going on bladder outlet obstruction. We know that, especially looking into longer-term studies, alpha blockers are more efficient in patients with smaller prostates, smaller than 40 milliliters, and they are actually having similar efficacy across different age groups, and their persistence their efficacy is persistent in the long term. And they do not prevent occurrence of urinary retention, or they do not decrease the need for surgery to our current knowledge. The side effect profile basically involves the vasodilating effects of the alpha blockers, which can be seen as asthenia, dizziness, or orthostatic hypotension. These are, of course, more pronounced with non-selective alpha blockers. The silodosin, for example, the alpha-1A selective blocker, has been found to be similar to placebo in terms of the frequency of hypotension. So we have to be careful, especially in the elderly population, about orthostatic hypotension, because it may lead to falling and hip fractures in that population, which may even consequently lead to mortality. A specific side effect of alpha-1 blockers is so-called the intraoperative floppy iris syndrome. This is more common with tamsulosin, but this is a class effect. Again, it can be seen with any alpha blocker. The take-home message here may be that the ophthalmologist should be informed about the use of alpha blocker prior to any, especially cataract surgery. Ejaculatory dysfunction is also another side effect. This is also related to subselectivity of alpha blockers, therefore more commonly seen with tamsulosin and silodosin. The good news is if the patient experiences ejaculatory dysfunction, his chances for symptomatic and uroflowmetric improvement is higher. And another take-home message that I would like to give is to counsel patients before prescribing alpha blockers about the risk of ejaculatory dysfunction is important. This is necessary to increase the compliance of the patient to the drug treatment. Otherwise, if you do not inform the patient about it, the patient can easily experience a panic attack after experiencing ejaculatory dysfunction. Now I would like to continue with the other monotherapy option, that is the 5-alpha reductase inhibitors. We have two molecules here, dutasteride and finasteride. And finasteride inhibits only the type 2 5-alpha reductase enzyme, whereas dutasteride inhibits both type 1 and type 2 5-alpha reductase enzymes, and therefore it's also called as dual 5-ARI. As we know, the type 1 is showing its activity in the skin and liver, whereas the predominantly the type 2 is active in the prostate. So what is the theory behind the mechanism of their action? They induce apoptosis of prostate epithelial cells by decreasing the dihydrotestosterone tissue levels in the prostate. So both finasteride and dutasteride actually cause the same decrease in the prostate level, but dutasteride decreases DHT levels more than finasteride in the serum. So they are equally effective in prostates larger than 40 milliliters. Dutasteride shows also its efficacy in prostates between 30 and 40 milliliters. The main difference compared to alpha blockers is the onset of action, actually. So we need at least 6 months of time in order to reach a clinical significant difference compared to placebo. So it doesn't have a short onset of action, and therefore it's not suitable for if you want to expect or get very quick responses. But in the long term, the 5-ARIs improve the IPSS and decrease the prostate volume and increase the Qmax. And here is the symptomatic outcome almost similar to the alpha blocker results. And in addition, they reduce the risk of acute urinary retention in the long term, and also they reduce the need for surgery. Dutasteride was shown as at least as much as effective as the alpha blocker tamsulosin, and here the greater the baseline of the prostate or serum level, the faster and more pronounced was the effect of dutasteride compared to tamsulosin. Most relevant adverse effects of 5-ARIs are related to the sexual function, and that are the reduced libido, erectile dysfunction, and ejaculation disorders. Gynecomastia is seen 1 to 2% of patients, although there has been quite a long discussion about the relationship between a higher incidence of high-grade prostate cancers or increased cardiovascular side effects. As of today, no causal relationship has been proven. So if you would like to describe an ideal patient for the 5-ARI treatment, we can just describe a patient with moderate to severe LUTS, with enlarged prostate larger than 40 milliliters, and a patient with elevated PSA concentration. And they can prevent the risk of acute urinary retention and need for surgery. And this is another main difference compared to alpha-1 blockers. Again, they are not suitable for short-term use. And not last but not least, their effect on PSA needs to be considered in relation to prostate cancer screening. And this is my last slide of this presentation. This is a case of a 48-year-old healthy man with benign prostatic enlargement and LUTS again. His IPSS is 18, but now he has mainly storage symptoms. His quality of life is affected, 4 out of 6. He has an active sexual life. He has a prostate size of 40 milliliters without a median lobe, and his PSA is 1. His bladder diary reveals decreased voided volume, increased frequency, without any global or nocturnal polyuria. Uroflowmetry results reveal a Qmax about 16 milliliters per second, an average flow rate of 9, and voided volumes could reach high as 200 milliliters. And he has a residual urine of 10 milliliter. I hope to discuss the case during our live webinar. I would like to thank you very much for your very kind attention.
Thank you very much. This was a great presentation and a good teaser for the live webinar. And that again is another just appeal to join us on March 23rd at 6:30 p.m. and then you will receive the answer to this case. Can I ask you a very last question to your presentation? It's a very simple question, yet I think sometimes it's really important. Fluid restriction. If a patient comes in and he says, you know, I drink a liter of tea at night, and therefore I have to get up at night to the toilet, fluid restriction is a good option. Does it help, or is it just, doesn't it matter?
Thank you very much, Kristen. This is, of course, a very important part of our clinical assessment. Here, actually, bladder diaries play a very important role in understanding the dietary habits of the patient. Usually, patients do not tell us how much they drink, or they may give easily wrong information. So I think to make sure, especially patients with storage symptoms, and yes, just directly as an answer to your question, if a person drinks too much or eats too much just before going to bed, of course, this will lead to nocturnal polyuria and nocturia in that patient. And in order to really understand what's going on and to build the dietary modification, we need bladder diaries in these patients.
That was a great finish. Thank you very much again. And I look forward to discuss with you more the mono treatment and treatment in general at the live webinar.